Welcome to everyone joining the webinar. We'll give people a couple more minutes to log in and then we'll get started. Welcome to everyone joining the webinar. We'll give people a couple more moments to log in and then we'll get started. Okay, so I think we'll go ahead and get started. Welcome to this webinar on IPV therapy for adult respiratory care, where we're going to go into the background of airway clearance and bronchial hygiene therapy and review a few case studies on patients receiving IPV therapy. My name is Brad Sexauer. I'm a clinical education specialist with Sentec, and I'll be moderating this webinar today. Before we begin, keep in mind you can ask a question at any point during the webinar. Just click on the Q&A button at the bottom of your screen and type in your question. We'll answer those questions at the end of the webinar. If you have any technical difficulties, go ahead and type those into the chat box. This course is accredited by the AARC and the California Board of Nursing for 1 contact hour. To receive your certificate, fill out the evaluation form that pops up at the end of the webinar. If you missed the link the first time, you'll also receive a link tomorrow in your follow-up email. Complete the form and include your license number if you have one. You'll receive a certificate by email, but be sure to complete that evaluation form to receive your CEU certificate. Now I'm happy to introduce our speaker, Andrew Klein. Andy started his respiratory therapy career in December 2003 and is currently the adult clinical education coordinator and an assistant professor in respiratory care division of the Department of Cardiopulmonary Sciences at Rush University Medical Center in Chicago, Illinois. He has been nationally recognized preceptor of the AARC since 2017 and is a member of the Mechanical Ventilation Domain Task Force at the American College of Chest Physicians. Andrew was recognized as a distinguished chest educator in 2021, 2022, and 2023, and was named a fellow of the American College of Chest Physicians in 2022, as well as a fellow of the AARC in 2023. He has lectured locally, regionally, and nationally, and has provided education for the ISRC, AARC, Chest, and the Society of Critical Care Medicine. With that, I'd like to welcome Andy.
Thank you so much, Brad. Thank you to the Sentec team and all the support they've given me over the course of the time building this talk, and looking forward to presenting this again. We had a great turnout this morning and I think presented some good information, so hopefully you all have the same experience. Also like to say thanks to my friend Tom Russell from Sentec for the introduction to the Sentec team. It's been a cool ride putting this together. So we'll get started here. I don't have any conflicts of interest that relate to this particular lecture, and I also wanted to just say that there's going to be multiple devices and therapies that are mentioned throughout this talk, and I don't have any personal bias. I've used all these devices personally in one way or another, and currently use several of them now, so I don't have a specific preference or bias towards any of the things that we'll talk about today. As far as objectives, I want to talk about the benefits and limitations of some of the current methods for lung recruitment, secretion clearance, and hyperinflation therapy. We'll look at several different modalities. I want to talk specifically about how IPV works and what sort of separates it from the group in terms of improving gas exchange abnormalities and secretion issues. And I want to talk kind of towards the end about, how we choose, or how maybe we can think about choosing the patients that have the best shot at being optimized by some of these therapies. So to get started, I kind of wanted to just really talk about what bronchial hygiene means. When I was growing up, it was aggressive pulmonary toileting, which was, I always thought an interesting term. But bronchial hygiene therapy, this is just one of, I'm sure, thousands of definitions that are floating around out there. I just like this one. It's a broad term used to describe various airway clearance techniques, and it can refer to chest physiotherapy, which is any sort of postural drainage, percussion, vibration, either during coughing or not, during suctioning or not. Breathing exercises could be huff coughing, diaphragmatic breathing, usually used more in spontaneously breathing patients. And then things like manual hyperinflation that's used more in intubated patients. So when we think about bronchial hygiene, why should we do it, or why would we want to? Well, really, at its core, the purpose is to improve secretion clearance, decreasing airway obstruction, and in doing so, enhancing ventilation and gas exchange, we hope. The goal should be, in adults and children, is to improve chronic and acute conditions that are related to that. This talk is mostly going to focus on adults, although we are aware that a lot of these therapies are practiced in children as well. The main focus of this talk will be adults. So in 1986, Philip J. Cole described this vicious circle of mucus production that we all have dealt with throughout our careers, I'm sure. And we get this secretion retention, causes some inflammation that messes with our lung function, and then we start to secrete additional mucus that gets then retained. Then we accumulate secretions, and eventually we accumulate enough that our airways start to get occluded. Then those secretions either get very thick or form actual plugs. This can be a great risk to the patient's health. And all of this works together to create this chronic inflammatory process in the lungs. And that inflammatory process then causes us to secrete more secretions. So you can see where this becomes quite an issue for us. So if we think about bronchial hygiene therapy and when it's most effective, or when we should really be considering doing it, if we want to have the best shot at optimizing someone, really in conditions with excess sputum production, and excess sputum production is going to be basically anything more than the 25 mils a day that our bodies are supposed to produce. And this could be any kind of acute illness with copious secretions, or any sort of acute respiratory failure related to retained secretions. We may find abnormal breath sounds, ABG values that are deteriorating, and obviously chest X-ray changes. These are all going to point us in that direction. Lobar atelectasis, which would speak more to that lung expansion piece that we briefly referred to, and then VQ mismatch. That's going to be created by some of these issues that we just talked about. So all of these things can lead us down the path of maybe considering bronchial hygiene therapy. Contraindications, in other words, why wouldn't we want to do bronchial hygiene therapy, is really dependent on the type of therapy. When we look at these therapies specifically in the next few slides, we're going to see that different therapies have different we operate them differently. They have different pros and cons, and we may have different contraindications depending on which one. But in general, trauma to the area that we may be using the bronchial hygiene therapy on, for example, if they have a rib fracture and we want to use vest therapy on them, and we're going to wrap their chest up with this vest wrap, or this vest piece, that may be a contraindication for that therapy just because of the trauma. Elevated ICP, untreated tension pneumothorax, unstable fractures of the neck, and hemodynamic instability, I would put those as contraindications for almost any respiratory therapy you can think of, because any of those could be made worse if improperly used with the therapy. And then the other thing that I would say that isn't necessarily on the slide, but I would add to this, is any therapy that takes a respiratory therapist or a practitioner in general away from other patients if we're selecting the wrong patient. So I think that should be a contraindication too. And we're going to talk about that a little bit more. Some of the acute conditions that we would maybe not consider bronchial hygiene therapy, that I think sometimes we do consider it, would be acute COPD exacerbation that doesn't have secretion issues. Pneumonia that doesn't have significant additional sputum production or secretion issues, and uncomplicated asthma. These are all things I've personally been asked to do CPT on at other, at different facilities that I can honestly say had no hope of helping because those aren't the right patients to do it on. So we're going to get into that in a little bit more detail as well. So when does it work? Well, we do have some data to show that it's been effective at secretion clearance, improving pulmonary function, and really moving secretions forward to where we can better manage them in things like cystic fibrosis and bronchiectasis, and even in certain situations, chronic bronchitis. Understand that these are diseases that have excess sputum production as just part of their normal disease process. So if we can optimize bronchial hygiene in those patients, we may keep them from getting worse as a result of those diseases and maybe lessen their exacerbations. So if we think about what works specifically, the main thing that you're going to find if you do a dive into the literature, the main thing you're going to find is body positioning and mobilization. In other words, if we get them up and walk them around, their secretions are naturally going to be processed. In other words, their body's going to do what it's supposed to do. So there's a reason in the post-op population why we get them up as soon as we can. Our open hearts here, they're supposed to be on their feet in 6 hours. If we're doing everything perfectly and they have no complications. And the reason for that is because that helps get their breathing back to normal, and it helps with any secretions that they may retain if we leave them laying in the bed. And then in things like cystic fibrosis, we have had some data to show that postural drainage and exercise combined with chest physiotherapy can maintain lung function for longer in that cystic fibrosis population. The other thing we think about in terms of why we use some of these techniques that we're going to talk about is recruitment of atelectatic alveoli. So what does recruitment actually mean? Now, I think we all have a handle maybe on what recruitment is as a concept, but maybe what recruitment is, just to define it, this may get us all on the same page. So for me, it is simply the opening of collapsed alveolar units. And typically, to do that, we would add pressure to alveolar units that are functioning well, and then use the connecting channels between that alveolus and the alveolus that are not functioning well, and use that in conjunction with tidal breathing to open those alveoli that we can actually recruit. So if we think about that, as we use our tidal breathing, if we add pressure to that and supplement the tidal breathing with some pressure, whether that be PEEP or whether that be positive expiratory pressure from one of our devices, that can, over time, recruit some of these alveoli. And this is what it looks like. So if I think about this, I have a nice open functional alveoli here. I have one that is collapsed here. And then for our purposes here, this one here, let's just say this is collapsed and filled with pus or some sort of other fluid, and it's not going to open anytime soon until we clear up some disease process. But this one here, if I increase aeration here and utilize these connected channels, I can pop these open that are like this. So that's really the goal of that therapy in terms of reversing atelectasis. The other thing to keep in mind here in terms of reversing atelectasis is this lower inflection point. Basically, if you're not familiar, the lower inflection point is the point at which FRC is optimized in any patient. So a lot of times if I have recruiting to do, then my patient's tidal breathing starts down here somewhere below that lower inflection point. And if I can add some pressure to this system through the use of these devices, along with my tidal breathing, I can get back over the top of this inflection point, which should be a goal of mine. And once I've restored FRC, that patient's lungs should function much more normally. So now that we've kind of talked about what bronchial hygiene is and why we might want to think about it, now I want to start talking about some of the types of therapy that we have at our disposal to utilize to get this done. So the first question I have for the group, I would like to know what therapies you guys have available in your facility, because I know this varies place to place, and there's different preferences and different prevalences of different types of therapy. So I have a list here in your poll question of the different, not all, but most of the different types of therapy you could have. So I'm just curious if you guys wouldn't mind answering that and telling me what types of therapies you guys use. Okay. All right. We had a little over 100 people respond to the poll. I appreciate that. And it looks like manual CPT. Obviously, that's a go-to. We don't need a whole lot other than ourselves to do that. We've got several people have cough assist and vest available, PEP therapy, which I'm referring to as like the some of the handheld PEP devices, which we'll talk about. Just like in the last group, the biphasic chest cuirass, this is a relatively new kid on the block. I'm not surprised that a lot of people don't have this yet and aren't utilizing this. And then it looks like OLE and IPV, about half or so have IPV, and then about a third have oscillation lung expansion or OLE therapy. So I appreciate that, and that helps me as we move forward to talk about these things. Okay, so now I'm going to start from the beginning, and I'm going to talk about postural drainage. And honestly, when I first started out and we were doing postural drainage, this is really what I thought we were doing. I thought we were just grabbing them by the ankles and shaking them and hoping everything ran to the top. But then, we learned from this bad boy here, which I'm sure those of you who went to respiratory school that are on the call recognize this picture or one like it, where we had to answer the questions on our board exams and what have you about what positions affected what lobes of the lung when we talked about postural drainage and percussion. As luck would have it, yesterday, I also teach a patient assessment class here at Rush with the master's respiratory students, and we did the bronchial hygiene lab yesterday. And one of the things in my station was postural drainage. So I literally pulled this slide up and we talked about the positioning. So this is still out there. This is still being taught for those of you who are wondering. So it's not going away. There is still some utility to this, especially if we use it in conjunction with some of these other modalities. So when we use postural drainage, there is usually a component of manual percussion or vibration. And we see the definitions here. Manual percussion would just be the application of physical energy. We've all hit these patients, I'm sure, with our hands on their back and their chest to try to move some of these secretions. And if we have them in the right position, that should optimize what we're doing with that. And then vibration would just simply be also with our hands, usually during a cough if we can, and just sort of rhythmically vibrate the chest wall while they're coughing to try to, again, assist with the movement of those secretions. So pros and cons, well, I mean, it's easy. I mean, clearly it's pretty prevalent. I mean, most of you guys answered that you have that functionality available at your hospital. So it's easy to actually perform, but it's hard to finish a therapy. I don't know how many of you have actually done manual CPT, but 20 minutes in, I'm telling you right now, your arms are feeling it. You don't need to do arm day at the gym after that. It does require no special equipment. It's the only one that doesn't require some sort of equipment to perform. And it is usually well tolerated by the patients. There's not too many patients who are like, oh man, I just can't do that anymore. With that, because we can vary where we're hitting them and even a little bit how hard we're hitting them if there is a tolerance issue, so we can get them through a therapy usually. Cons, though, it's time consuming. It takes a therapist away from the rest of their patients for 20 minutes at a time usually. And then if you have multiple patients per round that you're doing CPT on, that really cuts into what you can do with your other patients. And then it may not be as effective as some of the other methods we're going to talk about. We then have vibratory PEP devices or simply just PEP devices. And a PEP device is anything that creates a back pressure during breathing. And so this could and should improve alveolar aeration by utilizing that back pressure to add pressure to our tidal breathing for that recruitment that we talked about. If we add a vibratory component to that, it becomes vibratory PEP, and then we have that secretion mobilization aspect to the back pressure that we're using. This is not an all-inclusive list. This is just some of the, I think, the more common devices that we have here. This is the Easy Pap or the AccuPap. I apologize, I can't tell you which, but they both work similarly in that they use a high flow gas source to add flow to the system, and then upon exhalation, that flow creates the back pressure the patient breathes against. They're very small handheld devices, and you can use them relatively easily. Here we have several of the vibratory PEP device choices. We have the VibraPep here, the old school flutter valve, Acapella, and the Aerobica device. I know there are some others, but these are just some of the common ones that we use. Van Fleet in 2017 in respiratory care did a basically sort of an expose on these and sort of talked about how they all work. And this is just from that paper where he kind of broke down and had a nice chart that describes how each one works and what the functionality of it is to create the oscillations and the vibratory function of the device. So pros and cons. Pros, they're pretty much, you saw them in the picture. They're very small. They're handheld. They're easy to hold, carry, and use. You can take them with you you can take them with you to work if you have some sort of chronic disease. They're easy to move around. You can use a nebulizer with them, so you can sort of piggyback therapies there and still be effective with both. And because of the fact that they're pretty self-sustaining, you hook the neb up, you hand them to the patient, and once they've had that initial sort of training piece, they can do it on their own. So the clinician time becomes less there. Cons, the initial investment can be expensive. Those devices can be upwards of $100, $150, depending on which device you're using. It requires the patient to self-motivate and do the stuff themselves. And many of these devices are effort dependent, meaning you have to hold it a certain way, you have to breathe a certain way, you have to make some effort with the way that you breathe in order to get the most value from the device. So those are some things to think about with those. High frequency chest wall oscillation, which would be your external vibratory therapy, also known in most circles as vest therapy. This is a two-part system that contains the variable air pulse generator, which would be your machine itself, and then a non-stretchable either vest or wrap that goes around the patient's torso. And then what happens with this is the hoses, which I'll show you in the next picture. There are hoses that attach from the pulse generator to the vest device, and then this rhythmically sends pulses of gas into the vest device to externally vibrate the chest wall. This creates a repetitive cough-like shear force and can decrease the viscosity of the secretions. If they're thinner, they should be easier to mobilize and cough out. Here's the device. These are the hoses I talked about. They literally go from the pulse generator to the device, and then depending on how you have this thing set up, you can vary the frequency of the vibrations, and you can vary the force of the vibrations. You can also set a timer so that the therapy sort of runs on its own. Pros and cons. You get a more consistent delivery of percussion and vibration than you can with your hands. I don't care how good a shape you're in. There's no way 20 minutes into manual CPT you are giving as effective a CPT as you did when you very first started on that therapy. There's just no way to keep up the consistency. It's too much work. This can be done with less supervision by the clinician. Now, at my facility, our practice is you stay with a patient for the duration of whatever therapy they're getting. But in theory, if you have a stable patient, especially one that does these things at home that you can really trust to tolerate the therapy well and things like that, you could, in theory, get them all hooked up, get your machine programmed, and then you could go see another patient in an adjacent room. So that is a potential pro of that if you had the right type of patient to use that on. Some of the cons, obviously it requires a device, which can be an initial investment as well. And it's difficult to apply to an uncooperative patient. What does that mean? Well, in the ICU, we have a lot of patients that can't sit up in bed, can't, roll left and right for us when we want them to. So we need to physically manhandle them. And if we're talking about a 6'4", 280 patient, and I'm sure anybody who practices in the ICU have seen that patient, that just literally is just a lump of humanity in the bed, and then you have to manipulate them somehow to get that wrap around them. And then if you don't want to have skin breakdown, you have to manipulate them again to get the wrap off. So that can be a real dissuading factor with the vests there. Moving on to oscillation and lung expansion, or OLE therapy. This is a device, and you see two examples here with the Volera device and the Metaneb. And these create airway clearance by using alternating cycles of CPEP and high frequency, continuous high frequency oscillation to deliver pulses into the lungs. So this is a direct, this goes internal. It goes into the lung or into the airway in a rhythmic fashion. And you can also, to some degree, set up, the frequency and how those pulses are delivered with these devices. Pros and cons, it provides both positive expiratory pressure and oscillatory effect. You can, in theory, nebulize either normal saline or inhaled medications. And it can be used in a variety of clinical situations, meaning you can attach it directly to an airway. You can put it in line with a ventilator or non-invasive device. You can use it just with a mouthpiece or mask on the patient. So there's a variety of different ways this can be deployed. Again, cons would be it requires a device, which can be expensive initial investment, and the disposables can be expensive. Requires clinician time. In other words, you have to get everything hooked up. You have to get them situated. You, in some ways, have to coach them through the treatment, especially if they're not on a device. And in this one, in this particular therapy here, it's more of a one-size-fits-all mentality in terms of how that therapy gets delivered in terms of the frequencies and the force behind the air. Then we have true IPV, which is intrapulmonary percussive ventilation. You see the two devices here from Sentec. And this is, again, an airway clearance technique that uses a pneumatic pulse generator to send bursts of gas into the airway and down into the lungs. Again, this can be delivered with a variety of through a mask in line with the ventilator, mouthpiece, connected directly to an artificial airway. So we also have a lot of flexibility here. So some of the differences here, we can provide that positive expiratory pressure. We can provide high frequency percussive flow. This one is customizable. We're going to talk a bit about that. This one is more customizable to the particular patient. And we'll talk about how that works. Again, you can nebulize saline and other medications. We're going to talk a bit about that and what the best practices might be there. And again, can be used in any clinical situation and with whatever state your patient might be in. On the con side, very similar, requires the device. Disposables can be expensive. Requires clinician time, and in this case, which we're going to talk about, it requires a bit of expertise and training on the part of the clinician to truly optimize this therapy. So now that we kind of know what some of our choices are, how do we deploy this? How do we decide? Well, many places, and I've worked at a couple that have had these, some sort of a protocolized deployment of the bronchial hygiene stuff. Now we think about this. This is one example of a protocol, and we look here at the indications. Many of these protocols utilize some sort of a scoring tool to determine whether or not the patient meets criteria to have some sort of bronchial hygiene or lung expansion. As we see here, because we do already have some evidence that says in these particular disease processes there's some value here, a diagnosis of CF or bronchiectasis automatically qualifies them on this protocol. And then we have our, as we mentioned before, sputum production greater than 25 mLs in 24 hours, which would be our normal amount of sputum. Contraindications, just what we talked about, ICPs, uncontrolled hypertension, hemodynamic instability, active hemoptysis, and untreated tension pneumothorax. These are going to be contraindications pretty much no matter what we decide to use. So then the rest of this protocol essentially relies on finishing off your assessment, deciding, does this patient have the ability to breathe in a certain kind of way? If they do, we can try to start with our vibratory PEP devices. They're quick, they're easy, the patient can kind of do them by themselves. If they don't have an effective cough, or if they're not a good candidate for the vibratory PEP device, then we should be considering IPV. Again, this is one example of a protocol. There's probably hundreds of different examples. We also have an arm here where we could initiate vest. And then with this particular protocol, it has you go through and evaluate for improvement after the therapy is deployed. And I think that becomes the really important piece here, is assessing for improvement, assessing for decompensation, and then making some sort of a change in your strategy. I think that is the big take-home point. We're going to hit that again later. So now I want to take a minute and sort of dive a little bit deeper into IPV therapy specifically. So IPV therapy specifically really has two components. Has a control unit, which is the unit that generates the pulses of air that we talked about, and then you have the patient interface, which is called the phasotron in this case. And so one of the things you can't see from this picture is if you take this piece off the back, you can kind of see it's got like a raised piece here. You can actually turn that about a quarter of a turn and pull it out. And if you reach inside there, if you've never taken one of these apart, if you reach inside there, you're going to find a piece with a spring on it that has a Venturi device in it. That becomes very important, and it's really what sets this device apart from the others we've talked about, is that Venturi device, and it creates the piece that really makes this a valuable tool in your arsenal. So what does that do? The Venturi piece allows for air entrainment. Now, as you know from other Venturi devices, that air entrainment dramatically increases your total flow and thus the pressure you can create from that flow. In this case, it actually can control the velocity of the flow as well. And why that's important is what this does that's pretty cool that I didn't realize for the longest time. What this does that's pretty cool is that high velocity flow, instead of hitting those secretions or hitting that mucus plug and just sort of bouncing off of it or pushing it deeper into the lung, this high velocity way that the gas is delivered can actually squeeze air past the mucus or past the obstruction and get it to essentially come around behind those secretions, which is very, very cool. And there's some videos out there if you want to check those out. There's some YouTube videos and things that really show some cool lab experiments where they looked at what this does and how it gets behind secretions, and it's really something cool to watch. But clinically, that really adds to my sort of intrigue with this device, especially in certain populations, because now I have this option that really is going to create an environment where I can get behind some of these secretions that are in my way and move them in the direction I want them and not risk pushing them further into the lung. So, if we look here, this is something. So when we deployed this for the first time at my hospital, we had already been using oscillatory lung expansion therapy. We had already been using specifically the Metaneb device, which is why I say I don't have any bias. I mean, I use the Metaneb for years. We still have it here. I still use it. But again, recognizing what this does different is important. Now, if you look at this, and I'm certainly not going to go line by line here, but you can see that one of the apprehensions that my staff had was this is a bit more complicated to use, and this is why I said it requires some expertise, because there are a lot of adjustments you can make with this device to customize this therapy to your particular patient's lung mechanics and secretion characteristics. And so I can change the amount of pressure I'm using. I can change the frequency in a number of different ways that I can't with other devices. And then I can take advantage of this high velocity therapy to get behind these secretions and behind these plugs if I understand what I'm doing. So this is where the training and the expertise comes in. So what I did to demystify this for my staff a bit is I created this step-by-step guide on how to set this up and how to optimally set the settings and what to watch for. So that way, and these are laminated and hanging on every one of our IPV devices. Now, what that does for my staff is it gives them a comfort level until they get very comfortable using this device. So now they're not going to walk past it and grab the Metaneb because it's easier and because they understand it better. They're gonna sit there and say, okay, well, I can figure this out because I can follow these steps, and then I can sort of make these adjustments and utilize this device that may do a better job with that particular patient or that particular clinical issue that I'm trying to solve. So that becomes important. The high velocity therapy and the customization and the ability to tailor these settings to the individual patient and their particular lung mechanics, chest wall mechanics, and secretion characteristics becomes very attractive because when we were going over this yesterday with my students, I was explaining to them, okay, you have the MetaNev, you can use it, you hook it up, you do this, you do that. We talked about it, and I said, well, it delivers the pressure it delivers. It doesn't, not only does it not have the high velocity therapy, but I can't change the pressure. And one of my students was this little tiny 100-pound female, and then one of my students is 6'5", 320. And I said to the students, I said, so basically what happens is if I'm using the MetaNeb, if I hook Beatrice, who's the 100-pound girl, up, and I hook Mike, who's the 320-pound, 6'5", giant, they get the exact same therapy. And I put the question to them, do they have the same lung and chest wall mechanics, each of them? No, I hope that they don't think that. So if I choose the IPV instead, that gives me opportunity to customize Mike's therapy, the big guy's therapy, to what he needs, and then not overshoot maybe what Beatrice needs to be optimized. So it creates that flexibility, and that's a really comfortable feeling for a clinician if you understand how it all works. So let's get to what data that there is for us, because I don't think you can have a conversation about anything without looking at the data. So we're going to look at some data here in these next few slides. We're going to start in 2006 in the Journal of Critical Care. I'm gonna mess up this person's name, and I'm going to apologize to you all for that. Serrata, perhaps. Dr. Serrata and his group looked at the safety of IPV in obese patients with compression atelectasis. Now, these are patients with very low chest wall compliance who have issues with their chest wall and lung expansion. They found that the PF ratio improved at 3 hours from 189 to 243. Pretty significant improvement, statistically significant. PF further improved at the 24-hour mark from 243 to 280. Again, statistically significant. Dynamic compliance went from 30 to 35 at 12 hours, and then from 35 to 38 in the next 12. So lung mechanics improved on these patients by using the IPV with optimized settings. Pretty cool, I think. We're seeing a lot more obese patients in our ICUs and in our hospitals, and so their specific mechanics and treatment strategies are becoming more important. 2005 in critical care, IPV and acute exacerbations of COPD with mild acidosis. So Dr. Vargas and his group, here's the population they looked at. These are people who were at risk of respiratory failure but weren't quite there yet. They were well on their way, and based on decisions we made as clinicians, they were either going to fail or they weren't. And so they looked at this patient population and hooked them up to IPV. And as you see here in the results, we had an increase in PO2 and a decrease in CO2 with statistically significant value. In the control group, which didn't get the IPV, 6 out of 17, so a third of them, did have a worsened exacerbation, and 0 out of the IPV group did. Statistically significant. Hospital stay was shorter, and by quite a bit, by a whole, basically a whole day of decreased hospital stay. Again, statistically significant. So something to be said there about maybe IPV improving outcomes in these borderline COPD patients where, we make some decisions and they could go either way. IPV in cystic fibrosis. We look here and we see that they found equivalence in the secretion clearance compared to percussion and postural drainage. But what they found here, and this was in 1994, all right, and life expectancy, as you know, from 30 years ago for CF patients is considerably higher now, but this gave them some control of their bronchial hygiene regimen. They didn't have to have their parents or their friends or their spouse, if they got old enough, to perform these therapies. They could do it themselves. They could control when they did it. They didn't have to plan their life around someone else and X, Y, and Z. So that became a big deal for them. Now I want to talk just for a second about the clinical practice guidelines created by the American Association for Respiratory Care. Now, what they do, this is the professional organization for respiratory therapists, and what they do is they get a group of smart people together, and you see them all here, and they basically have them do a deep dive into the data and make some recommendations on different things. And in this case, non-pharmacologic airway clearance therapies, or ACTs. These are just some of the recommendations that they came out of those guidelines. And these were updated in 2013, probably due for an overhaul, but I don't think the data has really changed much. But CPT is not recommended for the routine treatment of uncomplicated pneumonia, not recommended for routine use in COPD, may be considered if there's secretion retention and well tolerated, and not recommended if the patient is able to mobilize their own secretions. Okay. And we think about the post-op population, IS for prophylactic use is not recommended. Early mobility is recommended, and airway clearance therapy routinely is not recommended in the post-op population. And again, they looked at somewhere around 80 different papers to create these recommendations. And anybody who works in respiratory, there's some pretty heavy hitters on this list. So these are very smart people that dug into this data, and these were the recommendations that came from that group. So the take-home point here, though, is they use words like routine use. In other words, don't not use it ever, just don't use it on every one of these patients, right? Not recommended, but it doesn't say don't do it under any circumstances. There may be those patients that you can look at that may benefit, and we're going to talk about that a little bit. The last question we have here is, should we nebulize medications if we use these, if we use IPV or OLE therapy? So there's been a couple of different papers that we'll look at here. Dr. Reichler and his group did 2 of these studies. And this one here, they concluded that they had comparable lung deposition, but a variable and unpredictable delivery of drugs to the lung. So they didn't recommend using the IPV to deliver medications because of the variable delivery of aerosol to the lung from the nebulizer. And they compared this to your regular jet nebulizer, which is the neb you use to give all of your other treatments. This was in the Journal of Aerosol Medicine, also Dr. Reichler's group. IPV delivered a much lower dose of amikacin compared to SST, which is what they described as the regular jet nebulizer, and the particle size was smaller. Only 5.6% was delivered by the jet nebulizer, and 0.8% was excreted by the kidneys. So basically what they did was they nebulized an antibiotic, amikacin, and then they measured what came out in the urine. So if it came out in the urine, the more that came out in the urine, the more that was probably absorbed systemically. So they could see that far less of it got down to the kidney level if it was delivered via the IPV nebulizer. Finally, I want to look at this study by some of my colleagues, Dr. Jay Lee, Dr. El Shafei, and Dr. Jim Fink. And they did this as a bench trial in 2020. We did it right here at Rush. And basically what they did, they compared different nebulizers and different placements of those nebulizers within a breathing circuit. And they found that the lowest delivery of all the things that they did was to use the regular nebulizer that the Menadeb had. The most efficient delivery was by a vibrating mesh neb, like an Aerogen neb, placed between the mask that the patient had and the ventilator breathing circuit. It was only 12.5% of the total dose of the drug, and it was by far the highest delivery. So no matter what we do, we're losing some drug, but we certainly should optimize as best we can. So based on the data that we have available, currently it seems like giving the medication separately in a different nebulizer format seems to have some value. So I want to finish up with some patient selection stuff. The slam dunk ones we know about are the CF, the bronchiectasis. You can attempt it with mucus plugging. Certain neuromuscular diseases, especially those that have secretion clearance issues. And so those are the ones that we kind of know more about, the fact that it should be effective, but I want to look at some situations where we might consider it otherwise. So I'm going to look at 3 cases here in the next 6 or 8 minutes. And I want to talk first about a 46-year-old male, came in with no significant past medical history, and we were suspecting pneumonia. So we had vital signs here. You can see here slightly tachypnic, slightly tachycardic, a little bit hypoxemic on 4 liters, okay blood pressure, elevated white count 31,000, and blood gases I'm not completely blown away by, but I don't love that they're abnormal either. Here was his chest X-ray. You can see here that we have a pretty clear right middle slash lower lobe infiltrate of some kind, and if we couple this with the white blood cell count and some other things, it's okay to probably call this a pneumonia. All right. Now, I want to ask the group, on this particular patient, should we do some sort of bronchial hygiene? If we do choose to do bronchial hygiene, to what end are we doing bronchial hygiene? What would the goal be? And then what are some options we might consider for this patient? So if you guys would take a second and give me some input on, if this was your patient, what you might think about doing. Okay. All right. So we had about 10% said that they're not indicated for anything. Manual CPT by a few, vest, cough assist, PEP therapy, probably little less than 25%. OLE therapy, and then we had probably a little over a third, not quite half, of the respondents said IPV therapy. Well, I can tell you that in this case, what we did was we did a trial of IPV, and our goal was at the time that we first saw this patient, they weren't coughing anything up, but we saw the X-ray, we saw the white count, and we thought, you know what? Maybe they're not coughing anything up because everything's really packed in there. You could see that infiltrate was pretty dense in that right lower lobe and kind of the middle lobe there. And so we thought, well, we'll try it. Let's do 2 or 3 therapies and let's just see if it starts to loosen anything up. Turned out that after about the 3rd therapy, patients started coughing a lot more stuff up. We were able to wean them off oxygen over the course of that next, basically over the course of the shift, and they dramatically improved. Now, when we first assessed them, they didn't have their breath sounds were okay. I didn't hear a lot of rattling or anything, that would indicate that they had secretions in there. It was just one of those things where I was like, okay, well, it's probably pneumonia. That means there's probably secretions in there somewhere. So we did a trial, but we had a goal in mind. Our goal was, let's do 2 or 3 therapies. Let's try to optimize this patient, and let's see if there's stuff down there that we're just not appreciating yet. So that was one application where we were able to do that. The next one I want to look at, this is a 52-year-old male with morbid obesity, hypertension, and type 2 diabetes. Kind of the trifecta, right? These morbidly obese patients in many cases have these disorders. Again, we've got a heart rate I'm not overjoyed with, but I'm fine with. A little tachypnic. This one a little bit more hypoxemic, slightly lower sat on a higher FiO2, and then still a blood pressure I'm kind of like whatever about. I'm not concerned about this blood pressure. This patient, however, when I auscultated, had coarse crackles, and when I heard him cough, he had congestion with his cough. You could hear it kind of rattling a bit. This was his X-ray. Now, when we look at this X-ray, you guys may see what I see, which is evidence of fluid overload. I see a pleural effusion here. I see a much smaller pleural effusion here. And I see a lot of pulmonary vascular distension and evidence of pulmonary edema here. I don't see dense infiltrates. I don't see evidence of pneumonia. I don't see evidence of secretions on this X-ray. So, again, my question to you, do you do bronchial hygiene on this person? They have evidence of fluid overload, but they do have coarse breath sounds. They have, some compromise with their hypoxemia. And if you did choose bronchial hygiene, what would your goals be, and what are the potential options you could choose from? Okay. All right. Again, we had a nice response. 120 of you. Looks like not indicated. I mean, I thought about it, right? Because it's a lot of fluid overload there, or a lot of evidence of fluid overload. Manual CPT, a couple of you, vest, a couple of you, cough assist maybe, PEP therapy, and then OLE some, and then IPV a few. Okay. So again, here's the deal. So you know, with the entire assessment, I mean, I saw what you guys saw. This guy's fluid overloaded. Done. Let's just, call him fluid overloaded and be done with it. However, I felt strongly enough about the fact of what I heard with the secretions. I was like, maybe there's some latent secretions down there that we're not seeing yet on the x-ray and maybe, aren't fully explained by the fluid overload. One way to find out. So we started this patient on IPV therapy. And again, with the goal, we're doing it for our shift, and let's see what happens by a shift changeover. Well, turned out after the second therapy, this patient started coughing up a bunch of yellow goobers. We were able to, we were treating the fluid overload too. We didn't ignore that. Patient was getting diuresed. But by morning, we had him weaned off his oxygen. He was breathing much better, feeling much better, and had coughed several times throughout the shift. He had coughed up a decent amount of secretions. So it turned out that maybe there was some secretions that were sort of hiding, if you will. They weren't necessarily super obvious on the x-ray. They weren't super obvious in the other pieces of the clinical assessment. The other thing we may have had an advantage with is by adding the positive pressure and customizing that positive pressure to this obese patient, we may have gained on it in that way too. We may have added and reversed a little bit of that chest wall issue like that first paper that we looked at from 2006. Last case here that I have, this was a 64-year-old male with COPD, hypertension, and hyperlipidemia, among other things. Again, heart rate fine, a little bit more tachypnic, and quite a bit more hypoxemic, but again, blood pressure was okay. This patient had coarse crackles and congested cough as well, and this was the x-ray here. Now you can see here we have a pretty significant, again, right middle and getting into the lower lobe here infiltrate, along with some scattered patchy infiltrate here. But obviously here is the elephant in the room. And we see here, we have a pleural effusion hiding down here, but we also have, if we look at the main stem bronchus, I can see right about here, that goes away because of a mucus plug that's in here somewhere. And so this happened about 11 o'clock at night, or at least we started to figure out what was going on about 11 o'clock at night. So now the question to you one last time is, should we do bronchial hygiene on this patient? What are the goals and what are some of our options? Okay, 130. This is great. Okay, a few didn't think they were indicated. I'm guessing the people that didn't think they were indicated would probably bronch them right away. Not a crazy thought. Manual CPT, vest, cough assist, a few in each of those, and then OLE, a few more, and then everybody wants to do IPV on this patient. There may be a theme here. And it turned out that this patient did get bronch the next morning. This started about 11 o'clock at night. However, here's where I think we benefited with IPV in this case, was we were able to clear some of these secretions. We were able to open up parts of that lung, and we were able to wean this patient's oxygen down to a nasal cannula throughout our shift, and this patient's respiratory status improved by a decent amount, so that when the bronch was ready to happen about 9 o'clock the next morning, this patient was in a much better place to tolerate that. And this way the team could get in there, they could spend a little extra time, get their samples that they needed, because this was an atypical issue that you guys kind of saw in that right lung. They wanted to get some samples. They were able to get that done because we were able to open them up and improve their pulmonary status throughout the shift and put them in a much safer situation for the procedure the next day. So even though we didn't fully save this person from a bronch or completely turn their condition around, we did probably put them in a much better situation to get the full procedure that they needed to get them the care they needed for a good outcome. So I am going to conclude here and give you guys some take-home points. We have a lot of choices to deliver bronchial hygiene. You saw many of them. There's even a few that I didn't get to in our talk here. Some disease processes may be more likely to benefit if we just look at the disease process specifically, and those are CF, bronchiectasis, maybe neuromuscular disease. I think, in my opinion and in my experience with bronchial hygiene, I think that patient selection outside of these groups is where where the hidden gems are that we may really be able to influence in a positive way. Um, IPV specifically offers flexibility and provides benefit in multiple ways because of the flexibility in deploying it, as well as the ability to customize it to whatever patient and whatever situation that you happen to be in. Retained secretions and mucus plugging may be good targets to start with to see what kind of benefit we can get. And certainly, as with many things, more research is probably needed, especially in these targeted populations, to see if we can get some outcomes to improve and spend our time in the right places and not do it unnecessarily on some of these populations that it's very unlikely to provide any benefit. I just wanted to circle back and mention again that I had no disclosures and that I had no bias toward any of the equipment we talked about. And I was just basically sharing my clinical experience with all of these devices and specifically some of the things that we've done with IPV that have been effective that may help you all to optimize your programs as well. So I appreciate everyone's time. Thank you very much to Sentec, and thank you to all of you who joined. I'm going to turn it back over to Brad.
All right. Thank you, Andrew, for that wonderful presentation. I think it's really helpful, really breaking down bronchial hygiene therapy. It's a good reminder for all the RTs out there what different techniques are good for certain patients, what are going to be, what's going to help accomplish some of those goals that you're trying to accomplish in your patient, and really all the critical thinking aspects of when choosing different bronchial hygiene therapies. So as a reminder, to receive your certificate, you'll need to fill out the evaluation form that pops up at the end of the webinar. If you missed that, you'll also receive a link in your follow-up email tomorrow. Remember that you must complete that evaluation to receive your CEU certificate. So fill out that evaluation form. All right, and with that, we'll get into some of the questions that we have coming through. So Andy, your last point on your conclusions mentioned that more research is needed, and kind of goes with this question, and maybe you might know a little bit about EIT, maybe not. But one of the they mentioned one of the difficult parts of IPV treatment is validation by literature. Do you think that EIT could be a good approach to evaluate airway clearances? Do you have any experience with EIT and IPV together?
That's a great question. I think just as a general point, I think EIT is going to have a major role in critical care in much the same way that ultrasound does now, and it didn't maybe 10 years ago. I think 5, 6 years from now, EIT is going to be at every bedside, and we're going to understand better how to use it. I have personally never used it in conjunction with IPV therapy, although I can see a pathway to putting those together and understanding better what's happening at the pulmonary level in much the same way we use EIT to optimize PEEP and other things like that. So I think that's a great point. I think there's probably an avenue for research there. We have started some research projects using EIT, not with bronchial hygiene yet, but with ventilator stuff. And I know I have some colleagues in Canada that are already using it at the bedside pretty routinely. So I think that's a great point. I think that's certainly something we should be looking into in the future as we get a bit more comfortable and we get some more of the approvals within our FDA to use EIT in the way that it's intended.
Yeah, perfect. And somebody in the comments asked what EIT is. It's electrical impedance tomography. Gives you a good idea of lung expansion. And so, as Andy mentioned, it's been used to kind of assess mechanical ventilation is whether or not you're optimizing settings. And it's kind of synonymous with, you mentioned, similar to an ultrasound, giving you a visual of lung expansion. Another question, if you're using IPV non-invasively, how do you instruct a patient while delivering IPV therapy? What's the best technique to tell them, to instruct them?
Fantastic question. And I think when you're using it non-invasively, I think that becomes the tricky part, because it does require a bit of cooperation by the patient. I can tell you I've gotten the best results having them breathe similarly to vibratory PEP. In other words, breathe normally, but with a full exhalation. When you feel like you fully exhaled, try to exhale just a bit farther. And I think that optimizes your back pressure and gives that expiratory phase that little bit of extra to optimize the vibratory piece as well. So I think for me, I think that is how I've seen the most success clinically, is try to have them breathe as comfortably as possible, but try to coach them through some prolonged exhalations whenever possible.
Perfect. Yeah, I think those are great instructions for the patient. Another question here, we have one in the comment and then one in the questions kind of related to the I time on the IPv2C. How do you decide when to adjust that I time, or do you adjust that frequently?
I don't adjust it frequently. I will say, I guess similarly to some of the reasons we might adjust it on the ventilator, I can tell you that if I use it in conjunction with a ventilated patient, whenever I possibly can, I take them off the device and put the device directly to the airway. That's something that my colleague Tom Russell, who kind of got me involved in IPV years ago, something that he always suggested, something I've always done in my practice, and I think you just get a little bit better delivery of the IPV. You don't have the ventilator kind of fighting against you with the breath delivery. I might use the I time if I were having some sort of oxygenation issue, because due to the Venturi device, you're not able to get 100% oxygen from the IPV device. So if you have a patient that has high oxygen needs, you may need to make some subtle adjustments that may allow you to take them off the vent and get a better IPV therapy. That's an example of what I might do, but I don't do it often.
Perfect. Yeah, I think that's a good thought process of how to think about potentially using iTime with IPV. With that, we're a couple minutes past the hour, so we'll go ahead and conclude this webinar. But I know there's a couple questions remaining out there, and we'll get back to you in an email to follow up with those questions that were remaining. But again, Andrew, thank you so much for this wonderful presentation. And everyone that participated in this webinar, thanks for joining. Thanks for your wonderful questions, and have a good rest of your day.
One last thing, Brad, before you log us off, I was just going to point out this last slide that's up there has my email, my contact info. I'm more than happy to, if you guys think of questions later, don't hesitate to reach out. And I know with the morning group, and I'm assuming with this one, Brad and the team are going to collate the questions, and I'm going to do my best to answer everybody's question through email. So I don't want anyone to feel like they won't get their questions answered, because this is something that's important. I think we can make a big difference with our patients if we do this right. So I'm happy to help any way that I can.
Absolutely. Perfect. Well, thank you so much for that, Andrew. And again, thanks everyone for joining. Have a good rest of your day.